أروى.
مرحبا يا أبو.
السلام عليكم.
وعليكم السلام ورحمة.
خلاص نبدأ.
أي نبدأ، ومبروك للجامعة.
الله يخليكي، شكرا جزيلا.
الله يعافيك.
قلنا ناشئة الأساتذة.
أي والله.
إن شاء الله. خلاص نبدأ إن شاء الله. بسم الله الرحمن الرحيم welcome to the Sunday lecture on tropical medicine, stroke medicine in the tropics. And we have been dealing with a lot of issues, diabetes, and other diseases which are prevalent all over the world. But we are stressing the importance of these diseases in the tropical environment. And we said we are changing the terminology from just tropical countries into low or middle income countries, which indicates not only the tropical, but also the countries in savanna or in desert, like Mauritania and others, where the common factors between tropical Africa and tropical Asia is poverty. And we have been outlining the importance of these variables or factors, which are very common and very effective in causing the disease and morbidity and mortality. Today, we are going to talk about hematology in the tropics. And hematology, heme is hemoglobin, and hematology is blood diseases, hematology or studies of blood disorders. It's very important. Anemia, for instance, is extremely important. We talk about anemia, we talk about abnormality in neutrophils, thrombocytopenia, like thrombocytopenic purpura. And then we're going to talk about abnormalities of the bone of the RBCs, which include sickle cell disease, beta thalassemia, and abnormalities in the RBCs, like serocytosis. So how would these diseases stand in the tropical environment? Definitely, some of it are related to the environment in the tropics, particularly poverty, lack of nutrition, malnutrition, and infections like HIV/AIDS. Malaria is a very important cause of anemia, for instance, and certain genetic factors which predispose some races to some of the genetic hematological abnormality. So let us talk about the commonest. The commonest is anemia. And anemia is an indication of low hemoglobin. So it's by definition, it's low hemoglobin, and hemoglobin is the essential factor. It's a spirit of life which carries oxygen, and that is extremely important. Hemoglobin is are in the RBCs, so it relates to the RBCs, the size of the RBCs, and the concentration of the hemoglobin inside. Anemia is very common in the tropics and, in fact, in all over the world, because it is related to other diseases. When I say anemia, this is not a diagnosis. Don't say my case has been a case of anemia. It is not. Anemia is just a clinical manifestation of an underlying disease. So anemia may be due to iron deficiency, folic acid, maybe to bone marrow infiltration by tumors, which is advanced, or fibrous tissue like myelofibrosis. So anemia is just a clinical manifestation, but by itself, anemia can relate to morbidity and mortality. We reckon that there are 2 billion people all over the world who are at any year suffers from anemia. 85% of those anemic patients are in Africa and Asia. So it is a disease which is very common in the tropics, and we will see the reasons why. But more so in preschool children below 5 and the pregnant ladies. And unfortunately, anemia contributes to maternal death in over 100,000 women yearly from anemia. They die from direct causes of anemia, and perinatal children, they die around about 500,000 child in the world die because of anemia. The level of anemia, the WHO has said that the level of anemia is according to the hemoglobin, and please go with the gram per deciliter. The reading should be gram per deciliter. Old readings like my hemoglobin is 50%, 80%, 70% is no longer valid. It's no longer valid. So even the WHO criteria of anemia is, variable, and it has been challenged because hemoglobin varies among races, in different races. So what is a normal hemoglobin in one race or one country is not the normal hemoglobin in other countries. So it is advised that all countries should do a survey of what is the normal level of anemia, what is the normal level of hemoglobin. But generally speaking, a child, should be more than 11 gram per deciliter. An adult man should be more than 13 gram per deciliter. And women should be about more than 12 gram per deciliter. So it is a degree. It's a degree of reduction of hemoglobin, and it is important to bear in mind if the hemoglobin is dropping, if the hemoglobin is stable, particularly in cases with high demand of nutrients like pregnancy. In pregnancy, there is at least 2-3 times demand from iron therapy because of the growth of the child. And children are all equally in high demand of iron and folic acid, okay, because they are growing. Again, in adolescence, particularly ladies, girls who just get the menarche are susceptible to anemia, especially with periods. In the early years of the girl, when they have the menarche, the menstrual cycle may not be irregular, heavy in quantity of blood loss, or frequent in metrorrhagia and menorrhagia. Either duration of the cycle will continue for 7 to 8 days, and or the bleeding is heavy. And because chronic loss of blood goes insidiously and slowly, the features of anemia may not be apparent. And if you ask a girl about, is the menstrual cycle regular? She says yes, regular. Heavy bleeding? No. But if you ask about how many pads does she change, then she talks about 3 or 4 pads, and this is abnormal, heavy bleeding, because she is used to it. I mean, she never tested something else. So go into depths of asking about causes of anemia, especially in young ladies. So let us concentrate on, we have the preschool children are more prone to anemia, pregnant ladies are more prone to anemia, and then infection. In the tropical countries, infection is very important as a cause of anemia. HIV, in HIV/AIDS, 70% of the patients will be anemic. And malaria is a very important cause of anemia in the tropics, and it does increase morbidity and mortality. So these infections. And if you talk about worms, you can talk about Glistoma duodenale, which is hookworm. And this worm is particularly common in tropical areas where the environment and sanitation is not up to standard, because the larvae of the hookworm will penetrate the feet, the bare foot of a child, usually child, wading in a rotten area or full of feces, and the larva will come and penetrate and gets into the body. And the adult worm settles in the duodenum. It suckers, it sucks, it just anchors itself to the duodenum and causes bleeding by the ulcers. Not only that, loss of blood, but also it sucks, it feeds on the blood. And this is a very important cause of iron deficiency anemia in the tropics. Schistosomiasis, again, is a cause of anemia, mainly blood loss anemia, because of, dysenteric, colonic loss of blood in S. mansoni, and urinary terminal hematuria in hematuria. So this is another cause of anemia in the tropics, which is common. But by and large, the most important cause is nutritional. Nutritional anemia in the tropics. Poverty is hallmark of certain societies. They are not feeding well, and they are not feeding their children well. What are the factors? The factors are that people are unaware of what to eat and what not to eat, and what is the good food for the child. For instance, if we talk about a child, he's breastfed, but sometimes he is given cow milk, okay, or given certain vegetables, and this certain vegetables may contain phytates, pH, phytates, which absorb the iron and cause iron deficiency anemia. Cow milk contains less iron, okay, and it is, if you feed the child on cow milk, then you end up with iron deficiency anemia. So it's an educational problem as well in the children. And then in pregnancy from the day dealing with a state in the lady which demands a lot of nutrients, almost double or three times the nutrients which are needed for an unpregnant lady. So if you are going on just an optimal level of iron in anemia, if your requirements is increased by pregnancy. So this is very common, and it is a cause, as we said, it is a cause of maternal death. Anemia by itself, for any reason, in pregnant ladies is a cause of increased maternal mortality. So, and this is very easy to to prevent in pregnancy. So I'm just trying to highlight those groups of patients or individuals who are prone to develop anemia. Children, neonates, and young infants, children below 5, okay, and pregnant ladies, and with infection, people with infection, and nutritional deficiencies, which may be absolute, malnutrition or everything, proteins, iron, folic acid, all the rest of it. Anemia will just be one multifactorial. It has many factors on top of what is available. So the child, the infants are rapid growth. Their nutritional status will go up, okay? It goes up 10 times per kilogram body weight. So for an adult who is just stabilized at some age and weight, a child who is growing rapidly may need requirements 10 times an adult per kilogram body weight. And this is very, very important to know because children are special people. And a child is not a small adult. He has his own environment, his own requirements, and he is prone to certain diseases which may not be, which will not affect adults. So it's important in that sense. We should look into the requirements of children. Okay, neonates, the state of a child born is a reflection of what has been happening intra-uterine. So the pregnancy, if it is healthy, if the mother is fed well, if there is no shortage of iron, folic acid, and the rest of it, then it is important that to note that the child will be healthy. If the pregnancy is affected by anemia, then the child will be of a small weight, may be premature, and may come out with anemia. So it is a reflection of the intrauterine status. We have to care about the mother, and when you care about the pregnant mother, we are caring about two people.
بروف صوتك ما واضح.
Hello, now you hear me?
Yes, we can hear you.
You can see? You can see me?
Yeah, yes. Yeah, we can
Okay.
see you.
Okay, so pregnant ladies is an area. So if you come out with this lecture by caring about pregnant ladies, caring about children, preschool children, and caring about infection, then you are coming out with some solutions to anemia. All right. So when we talk about blood components, we talk about RBCs, we talk about neutrophils, lymphocytes, basophils, eosinophils, and we talk about platelets, which is extremely important. All these components are produced in one manufacturer or one factory, which is the bone marrow. The bone marrow is fed with the precursor cells of all these components, and RBCs comes out from the megaloblasts, megalocytes, and they are shed into the bloodstream. RBCs have a lifespan of 120 days, and then it breaks into pieces. Okay, but these pieces are not lost because they recycle. Iron, for instance, is reuptaken, okay, to be used again in the new manufacturing of RBCs, new RBCs. So, and this is God's will, you know. This is وخلقناكم يعني في أحسن تقويم. And the body is recycling a lot of material, otherwise we will get dry. Look at the bile. Bile comes from gallbladder, from the liver, stored in the gallbladder, and under a male presence of a fatty male or male in the duodenum, the bile will get excreted to be used in emulsification of fat. Okay, the bile which is poured is obviously more than the need of the food, so the excess bile will go down in the small intestine, and which is the ileum. It gets reabsorbed into the system and goes back to the liver and gallbladder. This is definitely recycling. Otherwise, if bile goes in the colon, it causes problem and we lose bile. So the recycling is, think about it. You can find a lot of examples of body recycling, nutrients recycling cells, and in hematological area, the bone marrow is the essential site, it's the sole site of production of these indices or these organs or cells. The bone marrow will work under the response of erythropoietin, which is uh, secreted by the kidney. It's a hormone and goes from the kidney to the bone marrow, stimulates the production of erythropoiesis. When we say erythropoiesis, this is the manufacturing of RBCs, erythropoiesis. So it works under the effect of erythropoietin, and erythropoietin is released from the kidney under the pressure of hypoxia. So erythropoietin will definitely, if it is absent, as in renal failure, or if it is ineffective, as in infection or chronic inflammation, erythropoietin will be ineffective. Under these conditions, absolute absence, relative inefficiency, then the bone marrow will stop producing RBCs. Anemia can result from that. And now we can inject even erythropoietin by injection to patients who have chronic renal failure. Okay, having all the nutrients needed, there is no factory which can produce a product without raw material. And the raw materials here for the RBCs are one, and the most important one is iron. Okay, and then protein is necessary, folic acid of B12 are necessary for maturing or maturation of the RBCs, and then you will have vitamin A is also necessary, and zinc or cobalt, which are again important in the process of production of RBCs. Say it again, the protein is necessary, you need iron by and large, the most important element or raw material or nutrients. And then you have B12 and folic acid for maturation of the RBCs. You also require vitamin A, and you require cobalt or copper. And if the condition is favorable, then the RBCs will come out in a very good shape with normal volume and normal concentration of hemoglobin. And these are the two indicators of telling you if a patient is anemic, which is the size of the RBCs and then the concentration of hemoglobin in the RBC. So the RBC is released, then it circulates, when it's broken, it goes to the liver, and then it's reuptaken, the nutrients reuptaken for recycling, and so the kidney contributes to the hemoglobin concentration. Clearly, the bone marrow is the site of disease, site of the infection, site of the production of the hemoglobin. Okay, and then the gastrointestinal tract is definitely the site of absorption of the necessary qualities. Okay, in that sense, we can determine what are the causes of anemia. What are the causes of anemia if any of these areas is disturbed? If the bone marrow is under stress, if the bone marrow is under stress, then it produces younger RBCs. And the younger RBCs, which are produced prematurely, are called reticulocytes. reticulocytes. And if you stain the blood, then the reticulocyte will appear like blue, Reticulocytes is a sign of stress bone marrow, and even is a sign of activity of the bone marrow. Okay, so if you are treating a disease, then the bone marrow will be happy about the new nutrients and then starts multiplying a lot of RBCs and dishing them out. Sometimes they dish the RBCs out, and then the reticulocyte will appear in the blood. So this is an important sign also of anemia, presence of reticulocytes. Generally, if you go to the laboratory part of the anemia, then you should be guided by the clinical features of anemia. Okay, anemia may be caused by acute incidences, like if you lose blood, if you vomit blood from severe varices or duodenal ulcer, or if you lose blood massively in the colon, then this is acute anemia. And symptoms of anemia is often due to the rapidness of the occurrence of anemia. If you lose blood very rapidly, you will not only get anemia, and this is not will be the important part, but you will get shock because of loss of volume of blood. And here you can have collapse, you can have shock, you can have loss of consciousness, okay, with a low blood pressure and a rapid heartbeats. So that is acute loss of blood. But chronically, anemia may not have symptoms, not because the symptoms are not there, but the patient is being used gradually to the symptoms of anemia. Okay, so the chronic symptoms of anemia is, you feel fatigue, lethargic, lack of concentration. In children, they may have cognitive function, so their performance in school will not be good, psychomotor abnormalities, and المزاج is not good. So then this is a feature which may be loose, like an infection, like virus going into the body. But if that persists, okay, then you have to think of anemia, and then after discovering it's anemia, then you look into the cause. So this is some of the symptoms, and particularly in children, because they don't complain, but they feel fatigued, lethargic. They don't play with children. When they don't concentrate well, they forget. And when they go to school, they don't perform well. So you have to be aware of that. And chronically, the heart and the body would like to compensate. If you have reduced hemoglobin, then on that phase, the cardiac output will be increased to deliver more hemoglobin, because the content of hemoglobin is less. Then you develop more volume, and this is by increased cardiac output, and this will result in cardiomegaly, okay, as a result of anemia, and bounding pulse. The pulse will be high systolic, low diastolic, bounding pulse, like a collapsing pulse. And then you may find a merma, somewhat, what we call hemic merma, is due to the anemia. And when you examine the patient, you examine the conjunctiva, and the mucosa, oral mucosa, and this is the sensitivity of this conjunctiva mucosa to tell anemia is about 70%. So in at least 30% of patients who are really anemic, it cannot be perceived in the conjunctiva or the mucosa. So if a patient, don't feel like he's anemic pala, not pala, but you can still go on and confirm presence or absence of anemia by doing laboratory tests, which includes hemoglobin. So, and then you will look into the bed nails. This is again will show if the pallor is there. So you look into conjunctiva, the mouth, the mucosa, and the bed nails, and this is just like a 70% chance of getting the anemia. Okay, chronic anemia is associated with more changes, especially colonychia. Colonychia is either flattening of the nail or spooning, with longitudinal ridges and whiteness of the nail. And this is a sign not of anemia, of chronic iron deficiency anemia, colonychia. And you may find an esophageal web, like difficulty in swallowing. This is due to anemia. It may go on to the Plummer-Vinson syndrome, which is chronic anemia, dysphagia, colonychia, which is called Plummer-Vinson syndrome. That is also esophageal web current, which can occur with iron deficiency anemia. And it responds, even the web responds to supplementation of iron. So this is the physical signs, the symptoms, and the physical signs of anemia, and then the cause. Okay, when I examine the history of the patient, you have to examine about salient features of either blood loss, okay, nutritional factors, how do people feed, okay, and what do they feed with, okay, and then you have to ask about family history, especially if you suspect hemoglobinopathies, okay, and then habits, social habits. For instance, people may eat mud, which is pica. Some may taste and lick paints, okay, and this will cause iron deficiency anemia because it binds to the iron. And cleaves the iron in the feces, causing iron deficiency anemia. These habits, and usually in the children, eating mud is not uncommon in many areas, particularly in the tropics. So look for the cause and always look for subtle causes. Subtle causes meaning that things which are happening for years, but in small amounts, Piles is one of them. If you don't ask the patient particularly, and especially if a person is defecating in a pit latrine, he doesn't have the privilege of seeing his feces, then he wouldn't know that he is passing blood. Okay, some people, even if they pee blood, urinating blood, then they don't consider it abnormal. And we talked about schistosomiasis, remember? Children may see this is as a sign of puberty. So ask about these black stools, okay? May mean that you have a subtle cause like ankylostoma in the stomach, giving you anemia and deficiency anemia. So black stools is something which you should remember. And melena is by definition very black stools, glossy because of the albumin, and very offensive. Feces are offensive, but this is extra offensive. So this is occult blood in the stools and very easily tested, okay, by occult blood testing to see that there is blood coming outside. So that will need a detailed history of blood loss, nutritional, infection, that we'll get from the history. More often than not, there are other symptoms and signs. Okay, anemia, if you talk about 70% of HIV/AIDS has anemia, then definitely the symptoms of HIV/AIDS are there. So this is anemia does not present very rarely as a single abnormality. It usually presents with other symptoms and signs. Other symptoms and signs. So always think of anemia as a presentation, clinical presentation, and not a diagnosis. Having done a good history and very good examination, there are, as we said, there are signs which are just related to anemia, chronic anemia, but then you have to investigate what is the cause of anemia. If it's a deficiency, if it's an abnormal hemoglobin, if it is due to an infection, and so on. Okay, you remember children, neonatal children, then these may have low birth weight. So if you have a child with low birth weight, okay, investigate what is the cause of the low birth weight, and anemia may be one of them. If the child is premature, okay, needing a lot of support, oxygen, feeding, and warming, then you have to really detect if there is anemia or not. So the need for the formation of RBCs is very clear. It's very clear. So any deficiency of these factors will result in anemia, no doubt about that. So the greatest or the commonest factor of loss or inadequate supply is of iron deficiency anemia. Okay. So how can, by investigation, determine if the anemia is due to iron deficiency or otherwise? Okay. Or what are the cause of anemia? All right. We go with the hemoglobin. Hemoglobin may be low in all of them. Okay. And the degree of hemoglobin drop depends on where you started with. And as we said, hemoglobin may be different in neonates, all right, like 11, in preschool children, 11.5, in in ladies, about 12. In pregnant ladies is less, about 11.5 or so, because in pregnancy you have dilution of hemoglobin, and you may get falsely low hemoglobin. So bear in mind. And then in men, it is 13 gram per deciliter. Okay, the examination of for hemoglobin is easy. All right, now we have automation. If you go to people in Rwanda, if you go to Frontier, you can find a lot of machines which are automated. It will just give you not only the hemoglobin, PCV, RBCs count, white cell count, and differential count, platelets, and everything. It's automated. It doesn't need a lot of cleverness to get it done. But we have to think about areas where there is no automation like this. And these are peripheral areas. And these are the very areas we need to target for prevention of anemia. These are the rural areas. And there are other methods of detecting hemoglobin. All you need to say, this baby or this boy has a hemoglobin lower than normal or not. And this is why we use simple tests like hemo test or hemo test. These are very simple machines, can be operated by batteries, all right? And what it does is compare your blood, the color of the blood, against a standard color, okay? We used to have a Sally's method, and I think in physiology you may have seen it, Sally's method. Again, this is a cuvette. You put a cuvette or a color, of standard color, and then you talk about the relevance of your blood color and the standard color. This is why we used to say 20%, 50% because of that, because of the comparison. But nowadays, you have to talk about grams of hemoglobin in each patient. So hemoglobin can be tested by sophisticated tests or by simple comparison test, color comparison test. It is important to determine what is the cause. And for that, we have one index is the size of the RBC. Number two, the hemoglobination within the RBC. This is a normochromic. Normochromic meaning the hemoglobin concentration within the RBC is okay. So the cell may be normal or may be microcytic, smaller, or it may be macrocytic, big. Okay, for iron deficiency anemia, the cell is small, microcytic, and the concentration is low. Okay, the hemoglobin is low. So what we say in microcytic MCV, mean corpuscular volume is small, is less. This is microcytic, and then the hemoglobination is low. MCH, mean corpuscular hemoglobin, is low, and the ratio, mean corpuscular hemoglobin concentration, is low. So this is a straightforward sign of iron deficiency anemia. Okay, and that is not an end of a diagnosis, because when you say iron deficiency anemia, from your history, you know if there is blood loss or otherwise. But there are certain hemoglobinopathies, like thalassemia, like sickle cell, may cause microcytic hypochromic anemia, which is typical of iron deficiency anemia. There are other factors like polycythemia, you may find abnormal cells, but these are the essential ones. In megaloblastic anemia or folic acid deficiency or B12 deficiency, the cell is big and the hemoglobination is okay. Okay, so that is another big cells. But here you could look at the field, the peripheral blood field, and you can see other signs of megaloblastosis, megaloblastic anemia. And these will include hypersegmented neutrophils, which is again an indication of megaloblastic anemia, and goes with megaloblastic anemia again is low platelets. So you have other ways of telling, but then you have to measure. If it is microcytic, hypochromic anemia, iron deficiency, you should go for more tests like serum iron, like ferritin, like iron binding capacity, If these are abnormal, then you are diagnosing iron deficiency anemia, and by that time you have suspected it from the history from the patient, if he's losing blood, if he's not eating well, if he has an infection and so on. Okay, so the iron binding capacity is a measure. Usually the capacity will increase if there is iron deficiency. The capacity, you need the capacity. But ferritin may be less, okay? So it is something which you should note about. You are building the story now from symptoms, signs, and then peripheral blood. There is no anemia that can be diagnosed without a peripheral blood. So you really need a good peripheral blood to diagnose anemia. And very simple. If you see microcytic hypochromic anemia, then you are on iron deficiency anemia, full stop. Then you look into why there is iron deficiency anemia. Okay, let us concentrate on that. Okay, iron is found in meat and liver. Okay, there is iron which is found in vegetables, or other forms or vegetation, but this is not usually available for absorption. So the greatest content of iron is meat and liver. Okay, dates also thought to have high iron, but these are by and large the most important sources of iron. For iron, we need absorption. Okay, but before that, this is inorganic iron, which needs to be converted into organic iron to be absorbed. And here you need high acid in the stomach, which will convert the inorganic to organic. Okay, any factor which reduce the acidity of the stomach will decrease the absorption of iron. So if you have antacids, all right, if you have H. pylori infection, then this will interfere with the acids. Like there are, as I said earlier, phytates, Phytates, phytates. These are substances which are found in vegetables or certain vegetarian food, which will bind to iron and chelate the iron. And so, and calcium can chelate the iron. Chelation is you bind avidly to the iron and then take it down to the feces. Okay, this is chelation. And there are a lot of drugs which chelate, like penicillamine, it chelates copper. It just binds to copper, like in Wilson's disease, it binds to copper and then it goes in the feces. So chelates and phytates in certain food is causes the chelation of iron. So be aware not to take things like tetracycline, which again is chelating. Don't take antacids, and antacids can do it by two ways. Number one, it affects the pH and decrease the acid. The antacid will decrease the acid, so it will prevent conversion from inorganic to organic. And then the other chelating agent. Okay, the gastritis, any deformity of the stomach or the intestine, or any disease which affects the gastrointestinal tract may affect the absorption, not only for iron, for other things. Okay, celiac disease, for instance, malabsorption, all right? All these can cause iron deficiency. Okay, this is why I'm stressing the point that anemia is maybe co-factored by other diseases and other symptoms and other signs. Okay, so be on the guard to not miss other factors. So we already said about pica or pain or even ice. Some children are fond of eating ice. And again, this may cause iron deficiency anemia. A lot of ice may cause iron deficiency anemia. Okay, you have stomatitis, okay, glossitis, the tongue, all right, colonic, you have already said, and iron deficiency again, hair loss, particularly in women, and esophageal web, as we said, Romarkinson syndrome. Okay, the iron serum iron indicates the circulating iron. Okay, it may be less in iron deficiency anemia, but ferritin will be less. Okay, and total iron capacity will be high. Talking about chelation, I think even heavy drinking of tea can chelate, okay, and decrease iron absorption. So there are factors which you have to talk about, okay, and think about in terms of iron deficiency. Okay, in pregnancy, we have to talk about pregnancy because very small measures will prevent maternal mortality, will prevent anemia, okay? And in children, this is again important to the extent that now hemoglobin is being taken as an indication of good health system. If you survey, hemoglobin in children, then you will see if the environment is healthy or not. Because hemoglobin can be checked quantitatively. It's not something which is subjective from one person to another. It can be measured quantitatively. It can be repeated, and it has the beauty of being an indicator of recovery, either from intestinal worms or infection. So measuring hemoglobin is a very good indicator of health, a very good indicator of health. So in pregnant ladies, okay, we usually advise 3 visits to the health center. And these 3 visits are, the optimum, but one visit is good, but no visits is not good. This is why in Sudan, during the period of recovery of the health system, we intended to increase the primary health care system. The primary health care system. Women may feel lazy, may not go to the hospital if it's far away. But if the health center is only half a kilo from her house, she can even go while she's cooking. She just put the fire off, all right, and then go and have her baby examined, herself examined, her hemoglobin examined, her urine examined, and all this what you need in the primary healthcare system. Okay, and by this you can pick up a lot of abnormalities, and you can do a lot of good by preventing maternal mortality. Okay, this is the beauty of the primary healthcare system because it's very near. And simply, why should a pregnant lady go from the periphery to the center to have her hemoglobin measured? It's waste. It's waste of health resources. It's waste of women's time, and it is inequality in provision of health system. So you can even have a health system, a primary healthcare system with an ultrasound, and this is all what is needed for pregnancy to prevent prematurity, stillbirths, and maternal mortality. Okay, a lady goes there, she's be seen, and if the lady does not come, if the primary healthcare system is good, the midwife will go to the houses, knock house to house, asking about the ladies who are pregnant and examining them and giving them a card to come to the clinic for hemoglobin testing. This is how we reduce maternal mortality. Okay, and then we have to assess the feeding of the woman because we are not feeding one person, we are feeding 2 persons, one in and one out, the baby. Okay, so we are feeding 2. So the requirements is for 2, not for 1. And the consumption of the food is for 2. So it is important. We are doing the job for the future generation of babies. So if the care of maternity, then it is care of the future generation. Okay. In Sudan, between 11 and 19, the UNICEF has made a survey and recognized that 92% of women in Khartoum attend at least one visit to the health center, and 72% attend more than one. So there may be 2 or 3. And this is very good. There's very good indication of the working system, health system of primary care. So, having examined the blood film, and now we confirm by serum iron, low ferritin, high iron binding capacity, that there is iron deficiency, anemia, which need to be looked at and to find the cause. Okay, there are very subtle. If the patient is not complaining of black stools, you still need to have an endoscopy done, okay, because one of the common causes of blood loss is esophageal varices in tropical countries, particularly in S. mansoni, Schistosoma mansoni infection area. Okay, so endoscopy can be done. Examination of the back passage for hemorrhoids, and a proctoscopy or even a small sigmoidoscopy is important. And if you still think that the colon is a source of loss of blood, you have to do colonoscopy if there is availability. Okay, nutritional status can be assessed easily, okay, and a dietitian can be involved in the assessment of the dietary requirements. Feeding of children is a big chapter. Feeding of children is a big chapter. Mother milk is enough, totally enough for 6 months, but then you need supplement. And here comes the problem. You still need blood supplement for the breast milk. And if you can, if a lady can continue her breast milking the child, then it is good. Otherwise, if she's a working woman, she can milk it in a bottle and then give it to the baby. Later on, can be given to the baby. And the importance of milk, mother's milk, is it contains, it raises the immunity of the child. Cow's milk is, contains low iron, and it does disturb the absorption of iron. So if you are just feeding cow's milk to the baby, you beware if there is anemia or not. Okay, if there is iron deficiency, the first step, even before the microcytic hypochromic anemia appears, then the first thing is the stores. So the iron stores in the bone marrow will go less, okay? And then the iron binding capacity will start to increase, and serum ferritin will decrease, and serum iron saturation falls. And after that, after these 3 steps, you get microcytic.
Prof صوتك قطع.
هسي كويس؟
هاي
Okay, when we have an intervening call, then I think it cuts it off. It cuts the thing off. Okay, are we there? Are we still there? Okay, so in conclusion, we are talking about anemia, which is very common in tropical countries. In Asia and Africa, over 85% of all anemic burden in the world is in Africa and in Asia. Anemia is a contributing factor to a lot of disease, increased morbidity and mortality. It is a common feature of a lot of infections, particularly malaria and HIV. And with HIV, it reaches up to 70% of cases have anemia. Infection apart from malaria, you have the intestinal worms like hookworms, even ascaris in heavy infection. Then again, it leads to malnutrition and anemia. Anemia is very important in preschool children because it affects schooling, prevents school, uh, education, cognitive function, ability to walk, physical existence and physical fitness. In maternal, it's a major cause of death, just directly. If you are two people, two ladies, one is anemic, one non-anemic, they have a high chance of maternal mortality, and the total attributed total deaths of mothers, pregnant mothers attributed to anemia can reach up to 100,000 in the world per year. So we have talked about the different causes, the core morbidity of the other causes, and then when we zoom to iron deficiency anemia, which is one of the commonest causes of anemia worldwide. I think with that, we have expired our time, and I would like to thank you for being with me and looking forward to see you in another lecture in next week, Sunday. God bless. Thank you.